Alrighty, so we're going to get straight into this one today because I don't want to take up too much of your time. This session is one of the more basic sessions that I run for point of care, but the impact, I guess, of doing the right thing just via these two simple methods can really change the results that you are seeing. Please ignore the time I've put on the front of this presentation today. Clearly I forgot to change something. But the QR code should still work, and I have popped the QR code throughout the presentation where I get the opportunity. So you can just scan that in with your details. If you are struggling with the QR code, you'll see my phone number on there as well. So if it's easier for you and you want to have your details recorded on My Health Learning for attending this session today, you can also just text me just your name, where you're from, and your payroll number, and I'll do all the recording for you. But let's jump straight into this one. So just firstly, acknowledgement to country. So just acknowledging the traditional custodians of the lands on which we work and paying our respects to ancestors and elders past, present and emerging. I'm on Wiradjuri country today, and I am in fact a proud Wiradjuri woman. So just getting straight into it, just the basics of point of care testing for what you might not know is that we've got a pretty, I guess, big prominence in New South Wales at the moment, and particularly with this COVID outbreak, the amount of devices that we're seeing going into facilities is phenomenal. So we've got about 600 point of care devices installed over 180 hospitals, and that equates to about 34,000 operators. So as you can see here on the map, we are literally scattered everywhere. And we have a range of devices. So we have everything from the iStats and the Coagi checks, which, looking at the list that I've got today, is where the majority of you are from, like the devices that you're using, sorry. But then there are much bigger analyzers. There are analyzers sitting in the maternity space. But the ones I want to focus on today are our syringe-based devices. They're the ones that we see a lot of errors in, a lot of pre-analytical error, and there are really simple things that we can do to see better results. Better results means better treatment for our patient, and potentially not treating someone for a condition that they don't have, which I'll take you through in a second. So the whole reason for running this really straightforward and simple session today is because a lot of the time we do hear things like this, and that's that the machine is broken, the machine needs calibrating, the cartridges are faulty, the results cannot be trusted, or that PoCT is nowhere near as accurate as the lab. I'd be actually very surprised if any of you here in this session today haven't heard that at some point. The big issue is, though, that 70 to 80% of the errors that we see in point of care, so on our iStats, the GEM analyzers, all those syringe-based devices, they are pre-analytical. What does that mean? So it's the things that we're doing wrong during our collection and the handling of our samples. And I'm a nurse by trade, for those of you who don't know my background, and I'm guilty of every single one of these that we're going to discuss today. But that's a pretty phenomenal number, and the reason that I've started running more sessions on the pre-analytical things that we can do wrong is because it's a little bit terrifying to realise that you don't have the luxury of a lab. So we know ourselves, if we collect a really crappy sample and we send it to the lab, then the lab's going to call us up, aren't they, and they're going to say, hey Amy, you're going to need to do a recollect on that sample. You hemolyzed it, for example. We don't have that luxury in point of care, so us as nurses, doctors, we need to be able to identify on our results when we have potentially contributed to the result that we're seeing. So the two things that I want to bring across today that are going to drastically improve your results, number one is syringe etiquette. If you've attended a session with me before, you will be sick of me talking about it, but we're going to go through it again. So the first thing is to make sure you're using our heparinized syringes. If you're sitting in the Western area space right now, this is the guy that you're familiar with. You're familiar with this little fella, the 3 ml heparinized. So that's the first thing I want you to be doing, is just making sure you're always using a heparinized syringe, whichever's been allocated for use on your device, and not doing this. So we've all been there. I've been there, collected into 10 to 20 ml plain syringes. Then we just decant into tubes, and then we even save a little bit and we decant into our point of care syringe. So the reason that, actually, I'll just take you back a little bit and we'll have a chat about that. So the reason that I don't want you doing this is because 10 seconds is all it takes for clots to start forming in a plain syringe. So if I was able to be there with you today, we would play a bit of a game with a simulation arm, and I'd even do you a favour and I'd put a big 18 to 20 gauge in that simulation arm, and I'd time you to see how quickly you could pull the blood out of that sim arm into let's say a 10 ml syringe. The best time I have to date with that is 18 seconds, which isn't bad. The nurse, she was pretty impressed with herself, and so was I. But it's still too long. 10 seconds is all you have before microclots start forming in that syringe. Now, I'm not talking about the big gluggy clots that you can physically see with the naked eye. I'm talking about microclot. And microclot is really sensitive on our devices. Our devices pick it up. The iStat, for example, he picks it up and he starts throwing weird and wonderful results. In particular, and this is quite scary, this is where we see a lot of our false high troponin come from. Those little microclots sit along the sensors and affect the way it can read the result. And the other one we're seeing is potassium. We're seeing it affect potassium. You guys are all from small sites just like I am, so I probably don't need to reiterate to you the effects of a result like that in a small facility. You're going to ship those patients out. Now, I know there are times where you will have to collect into a plain syringe. For formal pathology, I'm okay with that, because you can use this big guy in the middle. So this is your blood transfer device, which I'm hoping that you're all familiar with. You just pop it onto the end of your syringe of blood, and that transfers the blood into the tubes for you. Absolutely, we don't want to be seeing this practice here on the left. And I feel like I can pick on the doctors today because I can't see any that are online. But I feel like as nurses, we've gotten quite good at getting away from this needle and syringe method and using a blood transfer device, but I still see a lot of doctors doing this. For point of care, absolutely not. There is no need to be doing a decant from a plain syringe into a point of care syringe. A couple of reasons for that. The first one is that there's honestly no need. If you're from Western, and most of you are, you have a Luer lock syringe, so it's going to attach directly onto your bung and allow you to pull that blood out. If you are from an area that isn't on this Luer lock syringe and you do have a slip tip, a little tip I have been shown by a couple of clinicians down around Westmead is that they pop the slip tip into the cannula and they turn it to about, say, 12:15. And that little bit of a turn helps to lock it into the bung so that they can then draw out their sample. So for point of care, we absolutely want you to be practicing collections directly into the syringe. For the cannula, that's a pretty easy one. You're just going to attach directly and draw out. For the butterfly, the same thing. You're just going to attach your syringe to the end of the butterfly and draw your sample out. Where that gets a little bit tricky for people is when they're on a butterfly method and they're using, they're wanting to collect formal pathology and a sample for point of care testing. So if you ever get stuck where you need both, here's what I want you to do in the future. I want you to grab this equipment here. So you can see here I've got a butterfly, I've got a bung, I've got my heparinized syringe, and yep, this one looks different again. There are heaps of, depending on where you are in the state, depends on what heparinized syringe you'll use. The blue guy up here is a Vacutainer with a blue top. I've also seen it with a purpley clear top. It's like the sister to the red transfer device you saw in the previous slide, but this guy, he can connect directly onto bungs. Also, just grab yourself some formal pathology tubes and some tape. And here's what I want you to do. I want you to, just going back, I want you to remove that lure lock on the end of the butterfly. If you're using a butterfly that has that sharp bit on the end, just be careful. Under that rubber, it is sharp. I want you to remove it, and I want you to place the bung in its place so it looks something like this. So you can see I've got the butterfly, I've got the bung on the end of the butterfly, and then I'm able to attach that BD lure lock device directly to the bung, and I can collect my formal path tubes. Now, this is where the tape comes in. You probably aren't going to find that in policy, but you've got a lot of work to do here if you need to collect formal path and a syringe for point of care. So once I stab my patient in venipuncture, I just lightly tape the wings down so I've got both hands to work with. After I've collected the formal pathology, I can take that access device off, I can attach my point of care syringe directly, and I can draw out my sample for point of care testing. The biggest question I'm asked at this point is, Amy, does it matter what comes first? Does it matter if I do point of care, then formal path, or the other way around? The answer is no, it doesn't. The only time it will matter is if you need blood cultures in with all of this as well. Blood cultures will always trump everything else. But if not, it's at your clinical discretion. For me personally, being at a small site, I will always take my point of care sample first before my formal pathology. The reason for that is if something goes wrong and halfway through that collection I blow the vein, at least I might have got enough for some point of care that I can run then and there, get some results and maybe figure out what's going on with my patient. But if I've done things the other way around, collected the formal pathology first, blown the vein, well then there's really nothing I can do with that except have another stab and hope I can get some blood. So the next one that we want to look at is, with your syringe etiquette, is volume. So volume is really important in point of care. So just as the microclot affect troponin and help and make us see all those false high troponins in particular, and some false potassiums, volume is also contributing in particular to false high troponin. You can see why people are thinking that way, especially when they take a sample for troponin. They think to themselves, well, I literally need a drop on that cartridge, so I'm just going to collect a drop. What happens when you collect a small sample like that? You end up with way too much heparin in too small of a sample size, in way too little blood, and that's what's affecting our troponins and giving us false high troponin. So a couple of basic rules is, number one, at least half the syringe size. So if you guys working on a 3 ml point of care syringe, minimum, absolute minimum 1.5. If a doctor hands you, and I am picking on the doctors a bit today, if a doctor hands you 0.5 mils and wants a troponin in particular out of it, I would be saying no deal. Minimum 1.5, better still, just fill it up, and then we don't have to worry about that inadequacy with the ratios. This is what we have seen happen, and my colleagues in the north ran this sample. Now, they ran it back when we were still doing troponins out of green top tubes, but same, tomato. But you can see here that they took a correctly filled tube and they ran it on the iStat and the lab, and they got similar results. Then they did the same thing, but they underfilled them And again, they saw the same results. I really like this little study that they did for a couple of reasons. It not only proves that the lab and point of care are as accurate as each other, but it was really good to see the impact that an underfilled tube syringe can have on your troponin. That's really significant for us, especially in small sites, because this is where we send patients out, don't we? We have a false high troponin. We send them off to Dubbo or wherever you're from. Like for me, it's Dubbo. They get down to Dubbo, some formal pathologies run, and it turns out the patient wasn't having a STEMI or a non-STEMI at all. So not only have you got to please explain to management for spending about $2,000 on an ambulance transfer, but you've also got a pretty annoyed patient that's now got to find their own way home. The other thing that we just need to make sure that you do is mix it well. So once you get your syringe, mix it well for 10 seconds between the palms and then follow it with 10 figure eights. We're really, really good at this, especially when we're working on the iStat. We're really good at doing this for the first cartridge that we run because we're walking our way to the device ready to run the first one. We're not so good when we sit it down, we get busy for a few minutes, we come back, we forget to pick it up and we forget to remix it. So they're the two basic things, is fill it up and mix it well. So the second thing, so we've talked about syringe etiquette. The second thing I just want people to start doing is thinking about the clinical considerations for your patient, because every single patient you see is different and is going to need point of care for a variety of different reasons. So what I mean by that is using your clinical critical thinking brains. Do not be afraid to ask questions. Number one, think about the tests you are running. So what's the most crucial result for your patient right now? And also asking yourself, is there anything that can affect the test results that I'm running? For example, a time delay. And the second thing to ask yourself is, are my results fitting the clinical picture of the patient? So am I confident that I collected a quality sample, to give me a quality result? Or should I be recollecting? Again, I'm picking on troponin a lot today, and I've got a different case study for you here in a minute. But we sometimes do see the 20-year-old, otherwise fit footballer come in and he throws a high troponin and everybody starts having a meltdown about how such a young bloke could be having such a high troponin. And sometimes the part that's missed is, actually, did I collect a good sample? Did I collect enough sample? And should I be running that test again? Those questions aren't asked. So I've got a bit of a scenario here for you. This is one that I get asked a lot of questions for, so I thought we would discuss it a little bit more in detail. So if you had a patient present to your ED with moderate shortness of breath, so let's say that they're a known COPD patient in your community, history of exacerbation, particularly in winter, they often require some periods on BiPAP. Their tripod positioning in the bed, they've got SATs at 83. Yes, I know this all sounds gross right about now. And it's lower than normal for them. So you know, because you see them a bit, that they sit usually around 90, 92. This patient also has some central chest pain. So at this point in time, you know a couple of things in the back of your head. You know that the doctor's going to want all three tests run on the iStat. They're going to want the Chem4, the Chem8 and the troponin. You've already recognised that this is an airway and breathing emergency, but you're also aware that the patient meets the PaCSA pathway due to their chest tightness. So we often get asked, well, what order am I going to run the tests? And this is the two common orders that we'll see. So we'll see some people decide to run their Chem4, then their Chem8, then their troponin, which is basically how we tell you to run most tests. But then we see a lot of other people go, well, no, crap, this patient's got chest pain. I'm going to need to run the troponin first, then the CG4, then the Chem8. And we see both. So I'm not sure right now what you're thinking you would pick. But if we chat about this a little bit further, so whilst absolutely we are taught that time is muscle, and we may be clinically inclined to run our troponin cartridge first, we also need to recognise the urgency of an airway and breathing problem in this patient. So what's going to happen, and I'll just go back, what's going to happen if we run that troponin cartridge first? It's going to take 10 minutes to get the result. In the meantime, that syringe of blood is left sitting on the bench, and a lot of people don't realise that metabolism and gas exchange and all these weird and wonderful things are still happening inside that syringe in 10 minutes. So whilst you're going to have a troponin result in 10 minutes, by the time you get to the gas results on this patient, which are pretty crucial because you've got an airway problem here and a patient that might end up on BiPAP again, these results are going to be pretty null and void, because too much time has passed, too much of a time delay, and the results have changed. So what you're going to end up with is invalid gas results, and you could possibly also end up with an increased lactate. So ultimately, due to the clinical presentation of this patient, we would opt for number 1. Okay? Don't also think to yourself, just because we tell you up here that option 1, CG4, Chem8 and troponin is the way that you should be running these cartridges. Now, the other reason for that is not just for the time delays and how it could impact your gas cartridge. The other reason for that is time, remembering that your CG4 and your Chem8 are only going to take 3 minutes each. There's also no reason why you couldn't do this though. And I got asked this recently. So you could also, for this patient, run the CG4 first, get an accurate gas result and a lactate because you've run it immediately after collection. But if then you're really, once you've figured out those results, if your next thing that you're really worried about is troponin, run it next, because your Chem8 cartridge is just your basic chemistries. There's no time delay here that's going to really affect the results. The biggest thing that could affect your results here is if you forget to do a remix. So in this situation, absolutely it would be okay to do CG4, troponin, and then finish on your on your Chem8 results, on your electrolytes. So my take-home message there, as you can see down the bottom, is just to get familiar with the tests on each cartridge. Know what you want for your patient. Know the limitations. So for example, our limitation here was delays in testing, because every clinical presentation you see is different and one size isn't going to fit all. The other thing I said to you guys was the clinical picture of your patient. So here's a case that actually presented to Gilgandra. She was 44 years old, fit woman, came in with a potassium of 6.5. What ended up happening here, you can see that over a short space of time, Gilgandra did a potassium and got 6.5. They repeated it again and got 5.7. Then they repeated it again and got a 4.1. What happened in that space of time was that the nurses questioned it. They said, I don't think these results fit the clinical presentation of this woman. And what they recognised is it was an error in their collection method. So the collection was really, really difficult. They took a long time to try and get the blood. There was a lot of excess force on the syringe plunger trying to pull the blood out. And they didn't get really big sample volumes. So kudos to these guys though. They continued to question the result until they took a sample that was simple, it flowed easy, and they got enough in their syringe. Potassium wasn't the only pre-analytical issue here. You can also see that they did pull a false high troponin up there as well of 0.18. Again, recognised their pre-analytical error, recognised how their collection technique and the difficulties they faced had impacted the result. So that's the big other take-home message for today, is just to look at the clinical considerations of your patient. So number 1, syringe etiquette, fill it up, mix it well before each test that you run. Number 2, your clinical considerations. Get familiar with the tests that can be run on your devices. Get familiar with the limitations of each test that you run. For example, the big one is time delays. And always, if something isn't fitting the clinical picture, always question it and consider going and doing a recollect, because that's always going to be safer for your patient than going and treating them on an incorrect result. For example, I can tell you now, for that patient I just showed you at Gilgandra, we had the doctor getting out the Actrapid and the calcium gluconate and the salbutamol all ready to go when she wasn't hyperkalemic at all. It was just a bit of a struggle on our part getting the blood. That's it for today, guys. Any questions before we round that up? Awesome. I take silence is golden. Well, thanks very much for attending today. And if you do have any questions, more than happy for you to flip me an email and we can go through them and whatnot. But thank you very much. Have a good afternoon.